Hello friends, this video is on arterial supply of heart. This is a very important topic and you will be definitely asked a question from this topic either in your part completion exam or terminals or your first professional exam. The exam questions can be a short note on arterial supply of heart or coronary arteries. You may be asked a long question on blood supply of heart. In that case, you have to write both the arterial supply as well as the venous drainage of the heart. Another question can be draw label diagram to show the arterial supply of heart, and you can be also asked to enumerate the branches of either right or left coronary arteries. Then you can be also asked questions based on clinical anatomy to give anatomical basis of angina pectoris, myocardial infarction, and why referred pain is felt in the precordium and medial side of arm and forearm in angina pectoris. Another question that can be asked is explain what is cardiac dominance and its clinical significance. This is often asked in viva voce examination. Now, if you get a short note on arterial supply of heart and coronary arteries, your answer should be written under these following subheadings. So first is introduction and the characteristic features of coronary arteries, their origin and course, the branches and distribution, and the clinical anatomy. So let us start with the introduction here. Heart is supplied by two coronary arteries, that is right and left coronary arteries, which can be seen in this picture. You can see here, this is the ascending aorta and these are the two branches from ascending aorta which supply the heart, that is right and left coronary arteries. The left coronary artery is the larger of the two and it supplies most of the myocardium of the heart, whereas the right coronary artery that supplies most of the conducting system of heart. So this you should remember, that left coronary artery supplies most of the myocardium, whereas right coronary artery that will supply most of the conducting system of. So what are the characteristic features of coronary arteries? They are different from other arteries. Coronary arteries, they can be considered as enlarged vasa vasorum that supply the heart. Heart can be considered as a big blood vessel. So therefore, the arteries which supply it will be the vasa vasorum of heart. They are the only arteries that get filled up during diastole. All other arteries are obviously filled during the systole. So during systole, when the ventricular contraction occurs, when the left ventricle contracts, the blood is pushed through the aortic wall which opens here. And you can see here the valves are pushed towards the wall of the aorta, ascending aorta here. So therefore, the blood will not flow through the coronary arteries. Whereas in case of the diastole, the backflow of blood which was pushed with the pressure, that closes the valve. So we can see here the valve is closed and the sinuses, aortic sinuses, they will be filled with blood. And now this blood will flow through the coronary arteries. They are the only branches of ascending aorta. Normally during Viva, you are asked to name the branches of ascending aorta. You forget that coronary arteries are branches of ascending aorta. They are functional end arteries. You must have learned that in general anatomy. So the anatomical anastomosis is there. It does exist at the precapillary level, right? But what happens in case there is any block in one of the branches of the right or left coronary arteries, the anastomosis, they are inadequate to compensate for this sudden occlusion. So therefore, they are called as functional end arteries because these anastomoses are not functional. They are just anatomical, end-to-end anastomosis. Let us look at the origin of coronary arteries. As I said earlier, they are branches of ascending aorta. The aorta here has got at its beginning three aortic sinuses which can be seen here. This is anterior aortic sinus and we have two posterior ones, right posterior sinus and left posterior sinus. So right coronary artery that arises from anterior aortic sinus, whereas the left coronary artery that arises from left posterior aortic sinus. So right coronary artery from anterior aortic sinus and the left coronary artery from left posterior aortic sinus. Course of right coronary artery, let us look at that. So it arises from the anterior aortic sinus, which can be seen here. This is the ascending aorta, and we can see the origin of right coronary artery. After its origin, the artery is going to run forward and to the right between pulmonary trunk and right auricle. This is what you can see here. It is running forward and towards the right between the pulmonary trunk and the right auricle. After this artery is going to descend vertically downwards in the right anterior part of coronary sulcus. So here this sulcus which you can see here, right, which is separating the atria from the ventricle, right, or this whole thing, this is the coronary sulcus or the atrioventricular sulcus. So the right coronary artery now descends vertically, you can see here, downwards in the right anterior. This is the anterior part of coronary sulcus and it is on the right. So right anterior part of coronary sulcus or AV sulcus till the junction of the right and the inferior border. So this is the right border here you can see, and this is the inferior border. So till their junction it will descend downwards. Now after that what happens? After this it turns posteriorly and runs in the right posterior part of coronary sulcus. So that can be seen here. It turns posteriorly or winds around the junction of right border and the inferior border, and you can see it is running posteriorly. That's why it is shown in dotted line. And this is which part of the coronary sulcus? The right posterior part of coronary sulcus. It's simple to understand that the right coronary artery will run in the right anterior first and then right posterior part of coronary sulcus. And next what happens? It ends by anastomosing with one of the branches of left coronary artery, which is known as circumflex artery. So here we can see it is anastomosing with that. Let us look at the course of left coronary artery now. So again we can see here, this is the ascending aorta. It arises from which sinus? It arises from left posterior aortic sinus. And after it arises from there, then what happens? This is going to run forward and to the left between the pulmonary trunk and the left auricle. So this is what you can see here. So this is running behind the pulmonary trunk, right? You can see here. So it will run towards forward and to the left between the pulmonary trunk and the left auricle. So it's very similar to the right one. That was running forward between the pulmonary trunk and the right auricle. And this is between the pulmonary trunk and the left auricle. But this is behind that. And then after that, it immediately, after a very short course, it divides into two branches. This branch is known as anterior interventricular artery and this one is known as circumflex artery, right? So we will look at them when we do the branches of the left coronary artery. And circumflex artery, which is this artery, is considered to be continuation of the left coronary artery. So divides into two branches, left anterior interventricular, also known as left anterior descending, right, and the circumflex branches. Now what happens is this circumflex artery that is going to wind around the left border of the heart and then run posteriorly in the left posterior part of coronary sulcus. So this is what you can see here. This is the circumflex artery winding around which border? This is the left border. And then it runs posteriorly, again shown in dotted line, in the left posterior part of the coronary sulcus. And how does it end? It ends by anastomosing with the branch from the right coronary artery. So this is the course of left coronary artery. Let us look at the branches of right coronary artery. So here one branch is given to the pulmonary trunk on the anterior aspect of pulmonary trunk. This is the pulmonary trunk with its left pulmonary artery and the right pulmonary artery branches. So first artery you can see here, the right conal branch. Then it will give many atrial branches on the anterior aspect also as well as on the posterior surface also. And one of the atrial branch is going to supply the SA node. So here we can see this branch is supplying SA node, and we call this as artery to SA node. This occurs in 65% of the cases. So in 65% of the cases, artery to SA node arises from right coronary artery. Then it will give ventricular branches, and one of them is very big. Here you can see this is the right marginal artery. This is big as compared to other ventricular branches, and this will run along just above the inferior border of the heart on the anterior surface of the right ventricle. Then we have many unnamed ventricular branches, both on the anterior aspect as well as will be there on the posterior aspect also. And another important branch which is given by right coronary artery is the posterior interventricular artery. The name is posterior interventricular because it runs in the posterior interventricular sulcus of the heart. And this artery you can see here is anastomosing with the branch of the anterior interventricular artery, which is a branch of left coronary artery. The posterior interventricular artery is also known as posterior descending artery by the clinicians. Now in most of the cases, it is the posterior interventricular branch which will give a branch to the AV node, which you can see here. So it will give a branch to the AV node, and this happens in 90% of the cases. So in 90% of the cases, the artery to AV node will be given by right coronary artery. Now areas supplied by the right coronary artery or the area of distribution. So it will supply almost whole of the right atrium, then ventricles. Which part? Right ventricle, whole of right ventricle except the area adjoining anterior interventricular groove. Here the left coronary artery branch, that is anterior interventricular artery, runs. So that is going to supply. So whole of right ventricle except the area adjoining anterior interventricular groove. Then it also supplies the left ventricle, where that is adjacent to the posterior interventricular sulcus. So near that it will also supply the left ventricle. Then interventricular septum. How much part? Posterior 1/3, because the posterior interventricular artery, that is going to supply, right, these areas. So posterior 1/3 of interventricular septum will be also supplied. And most of the conducting system we already know is supplied by the right coronary artery. In 65% cases SA node, 90% cases AV node, bundle of His and the Purkinje fibers, everything will be supplied by this except for the left branch of bundle of His. So this is the area of distribution of right coronary artery. Now branches of left coronary artery. So we can see here this is the left coronary artery running behind the pulmonary trunk here, and it arises from which aortic sinus? The left posterior aortic sinus of ascending aorta. So we can see here one small branch which is running on the surface of the pulmonary trunk, and this branch is known as left conus artery. Right coronary artery also gives a branch to the pulmonary trunk here known as right conus branch, and these two arteries will anastomose with each other. Then after very short course, the left coronary artery divides into anterior interventricular artery and the circumflex artery. So here we can see this branch, anterior interventricular artery. As the name suggests, this is going to run in the anterior interventricular sulcus between the right ventricle and the left ventricle. After that, it is going to wind around the inferior border and run for a short distance in the posterior interventricular sulcus and anastomose with the posterior interventricular branch of right coronary artery. This artery is very important clinically, and this is also known as anterior descending artery also. Most commonly blocked artery is this one, anterior descending artery or anterior interventricular artery. The other important branch is the circumflex branch, which is also considered to be continuation of the left coronary artery. This is going to wind around the left border, and you can see now it is running in the posterior, left posterior part of the coronary sulcus. So this is the circumflex artery. Now this circumflex artery will also give another big branch to the left ventricle, and this is known as diagonal artery. Sometimes the left coronary artery will divide into three branches: anterior interventricular, circumflex and diagonal. But normally the diagonal artery is a branch of circumflex artery and it supplies the left ventricle. Then we have unnamed ventricular branches from anterior interventricular artery and from the diagonal artery. And we also have atrial branches from the circumflex artery, and one of those atrial branches will supply the SA node, and this occurs in 35% of the cases. 65% of the cases, SA node is supplied by a branch from right coronary artery. So these are the branches of left coronary artery, and two very important ones you should remember, that is anterior interventricular or anterior descending, and the second one is the circumflex artery. Now area supplied by the left coronary artery or area of distribution of left coronary artery, let us see. First is left atrium, so most of the left atrium, then ventricles. Whole of the left ventricle except the area adjoining posterior interventricular groove, where the posterior interventricular artery is running, and most of the time that artery is a branch of right coronary artery. Then right ventricle, which part? Adjacent to the anterior interventricular sulcus, where we have anterior interventricular artery running, which is a branch of left coronary artery. Then interventricular septum, the anterior 2/3 of the interventricular septum, right, that will be supplied. So that's why in the beginning I said it supplies most of the myocardium. Left atrium is whole supplied by that. Left ventricle, which is actually its wall is 3 times thicker than the wall of the right ventricle. So almost whole of the left ventricle is supplied by this. And how much of interventricular septum? Anterior 2/3. Right coronary artery supplies only posterior 1/3. So that's why most of the myocardium is supplied by left coronary artery. Then it also supplies the conducting system, but SA node only in 35% cases, AV node only in 10% of cases, and only the left branch of bundle of His is supplied by the left coronary artery. Now, what is cardiac dominance, right? Or coronary dominance, it is known as. The coronary artery, which gives rise to the posterior interventricular branch. We can see here, this is the right coronary artery, and the posterior interventricular branch is coming from right coronary artery. Whereas in this case, if you see, the posterior interventricular artery is a branch of left coronary artery, right? So that determines the coronary dominance. If posterior interventricular artery is a branch of right coronary artery, you will call it right coronary dominance or right cardiac dominance. If it is a branch of left coronary artery, then you will call it left coronary dominance or left cardiac dominance, right? Otherwise, there is another criteria, the artery which crosses the crux of heart. The crux of heart is where the coronary sulcus meets the interatrial sulcus and the posterior interventricular sulcus. So the artery which is going to cross the crux of the heart obviously will give the posterior interventricular branch also, right? So this is about the coronary dominance here. Now, if the posterior interventricular artery, this occurs in some cases, arises both from the right coronary as well as from the circumflex branch of the left coronary artery, then the coronary circulation is known as codominant or balanced circulation, right? Approximately 70% of the population are right dominant, 20% are codominant, and 10% are left dominant. Now, what is the clinical significance of that? As I said earlier, that the left coronary artery supplies most of the myocardium of the heart. Now, suppose the posterior interventricular artery is also a branch of left coronary artery. Then in that case, what happens? The whole of the left ventricle will be supplied by branches from left coronary artery, because only a part of the left ventricle which is near the posterior interventricular septum is supplied by right coronary artery usually. But now that will be also supplied by the left coronary artery, plus The posterior 1/3 of the interventricular septum will be also supplied by that. That means the whole of the left ventricle and whole of the interventricular septum, that will be supplied by the left coronary artery. And if there is a block here in the circumflex artery or in the left coronary artery, that can turn out to be fatal, because the blood supply to the whole of the left ventricle and interventricular septum, that will be affected, right? So this is the clinical significance of cardiac dominance. Now there is a condition known as angina pectoris. Angina, that is pain, occurs. Why it occurs? Now here the severe pain chest will be felt. Why it will be felt? Because of ischemia. What is ischemia? Lack of blood supply to that particular part or to the organ, and hence obviously the oxygen supply will also decrease to the heart muscle. Okay, so here we can see because of the narrowing of the blood vessel it may occur, which we can see the enlarged view here. The plaque formation has taken place and the lumen has become narrow. As a result, less amount of blood will be flowing and will be supplied to the myocardium here. So it generally occurs due to partial obstruction or in some cases spasm of the coronary arteries, which may occur as a result of sympathetic stimulation. Then the obstruction is usually due to atherosclerosis, that which occurs, the plaque formation with the aging. So here the blood supply is not completely blocked, right? It is actually the vessel has narrowed and the blood supply has decreased, right? In case of angina, there is moderate to severe pain in the left precordium, that is in front of the heart, right? Sternal region here. So left precordium, and we call this condition as angina pectoris. The referred pain in angina pectoris can be also felt in the shoulder, ulnar side of the left arm, forearm and hand. So that can be also felt. Now what is the reason why this referred pain in angina pectoris is felt in the medial aspect of left arm, forearm and hand, and also in the left precordium? This is because of the nerve supply, because the same spinal segments, they are going to supply the heart as well as the precordium region and the medial aspect of left arm, forearm and hand. Heart is innervated by T1 to T4 or T5 spinal segments. The skin over the precordium is also supplied by T2 to T4 spinal segments, and the skin over the medial aspect of forearm and arm is supplied by T1 and T2 spinal segment. So we can see here the same spinal segments are supplying. Therefore, the cardiac pain is referred to precordium and medial aspects of arm and forearm because of the same spinal segment innervation of these structures. Now, what is myocardial infarction? Infarction means the tissue becomes dead here. So this is also known as MI or heart attack by a layman. And this results from interruption of blood supply to a part of the heart. So here there is complete interruption of the blood supply to the heart. You can see here, right? So there is a block here, a clot could be there, or the vessel, right? The plaque formation is so much that the blood cannot flow from the proximal to the distal part of the coronary arteries. So this leads to myocardial ischemia. Obviously the blood supply is not there to the myocardium, which leads to myocardial infarction, which is also myocardial necrosis. The death of the myocardium, which is not getting the blood, that will occur. Now, prognosis of coronary disease is better in old age than in young people. Why is it so? The reason is, as I said in the beginning, coronary arteries are functional end arteries when people are young. And why they are functional end arteries? Because they anastomose mainly at the pre-capillary level, and in case of a block in one of the main branches of coronary artery, the collateral circulation is not adequate enough to compensate for the block, right? So that is the reason. So in case of block of the coronary artery, these anastomoses are not effective in young people, and as a result the coronary disease can be fatal in young. Whereas what happens in old age? in old age, because the anastomosis increase, because there is gradual narrowing of the coronary arteries, and the collateral channels, they develop and they become large enough also. So the collateral circulation is possible with advancement of age. Therefore, prognosis of coronary disease is better in old age than in young people. So that's all for this video. Thanks for watching, and if you have not subscribed, please subscribe my channel so that I can put more such videos. And if you want the questions and answers in anatomy, all types of that, then visit the website, that is anatomyqa.com. Thanks once again.